Leanne, sources of protein powder other than dry milk.
Benny's Protein is a product put out by one company.
Microphones. There we go.
Okay. Benny Protein is put out by a company that you can get this through a medical durable. If you have problems getting it, let me know. ProCell is another one. And ProMod, which is put out by Abbott.
Okay, anyone? Which protocol drug combination has been shown to shrink peanuts? Let's get Ed.
Which
What
protocol?
would you use if you had somebody who wanted to try to make them resectable? What would you use in a peanut?
In peanuts, unlike carcinoid tumors of the small intestine, for example, the most rapid and good shrinkage of tumors happen with cytotoxic chemotherapy, even more than the biologic agents. So the most active thing that would be temozolomide and Xeloda, what we talked about before, capecitabine and temozolomide, would be my first choice, although that is not approved drugs yet for tumor of the pancreas.
What about
Yeah.
strep Adria? Strep 5FU?
It's probably just as good, although they haven't been compared head to head, and that would be a more standard treatment also available.
Okay, Dr. Howe, taking too much calcium linked to hypersecretion of gastrics, i.e. milk alkali syndrome.
Yes.
Good. Dr. Wolin, research relating to show the success of retarding tumor growth in lung carcinoids through the use of octreotide. And how do you determine what kind of receptor someone has to maximize the use of somatostatin therapy? I'll tell you that there are no tests for somatostatin receptor subtype 1, 2, 3, 4, 5. There is a gene expression stuff that I'll talk about tomorrow. Let's talk about the lung thing.
Okay, lung thing.
Lung thing, use of octreotide to slow down the growth of lung carcinoids.
Okay, lung carcinoids, which are we're defining as low and intermediate grade, well-differentiated lung carcinoids, the kinds of things that will often work, even though it's not studied in a prospective randomized trial like ProMid for small intestine. We still use octreotide, particularly in those individuals with positive octreotide scans. There's also evidence that mTOR inhibitors are good for the situation as well.
Dr. Raines, is there anything such as an ileal cecal valve transplant?
There's no such thing as the ileal valve transplant. No, you can somewhat recreate some valves in the intestine, but not really in the small bowel at that site, as far as I'm aware. I'm not a surgeon, but no.
Yeah, there was a guy named John Sawyers and another guy named J. Linwood Harrington who were from the Nashville General Hospital and St. Thomas Hospital in Nashville, who basically took a very, very short segment of bowel and turned it at 180 degrees so it went upstream rather than downstream. And they caused buku problems you don't want to talk about. Had colon resection for carcinoid of the mesentery, liver mets detected on octreotide scan. Should I consider CERT? Doing samprostatin injections, still flushing. Steve, where do you put CERT in resection, taste, bland embolization? We're going to have a talk on this tomorrow, but where do you put CERT in?
All right, so I put resection at number 1, 2, and 3. So if it's resectable, liver metastases, resection is not only going to effectively treat the symptoms if the patient's otherwise a good candidate for surgery, but as we've shown, there is a positive impact on outcome. After surgical resection, you're really trying to balance risk-benefit of the treatment you're doing. Many of those treatments will be effective at managing symptoms because they'll chemically or radiologically debulk the tumor for a period of time. And so I generally try to pick the one that is most straightforward to do, least side effects, the one you can do most often, etc. And so I kind of look at the rest of them kind of in a similar bag.
If you've ever heard me talk, I talk about the teeter-totter. Effectiveness on one end and side effects on the other end. If you got a mouse over here, you need a mouse over here. You don't need an elephant. If you got an elephant over here, you got to have another elephant. So big risk, big benefit, little risk, little benefit is the way to think about it.
Yep.
Leanne, red or white wine? Which one do I drink?
I drink them all!
I actually drink Jack Daniels.
Depending on what you're eating with the meal.
As now Emerald tells me that ain't so.
If you're flushing, just stay away from the alcohols overall. Detox, red wine if you're trying to get the benefit of grapes.
Right, resveratrol. You can also buy it in a pill. Danny, everolimus causes diarrhea. Is the mechanism of everolimus, or Ed, you're an everolimus guy, what's the mechanism of everolimus that induces diarrhea?
It's my understanding it's enteritis, but I haven't written that drug much.
Okay.
I mean, it's
Ed,
inflammation
you're
of
the
the
everolimus
intestine.
man.
Yeah.
Okay.
As well, that's an enteritis.
This is for
It's very unusual though. It's not a common side effect of everolimus. There are more common ones, but diarrhea is not all that common.
mouth ulcers.
Mouth ulcers, rashes, hyperglycemia.
Hypertension.
Yeah.
Okay, whoever is out there, I guess that'll be me. How come carcinoid patients can take SSRIs? Because SSRIs, if you've ever seen the story, is you got one part of the nerve here and the other part of the nerve here, and it's sealed in a balloon. And the SSRIs only change serotonin between this part of the nerve and this part of the nerve. What's right in here? It doesn't get out into the circulation. And remember, serotonin, radioactive serotonin given in the IV doesn't make it to your brain. Radioactive serotonin put in your brain doesn't get out to the circulation. There is a blood-brain barrier. This don't go there and there don't go there. Okay. That's next. All right, Dr. Wallen, compare the side effects of octreotide and lanreotide specifically now. Don't give us any generality. Diarrhea, abdominal pain, gas, etc. They've never been compared head to head.
They've never been compared to head-to-head. Anecdotally, it's very similar, and also anecdotally, the diarrhea and gas and all of these symptoms are usually due to pancreatic enzyme deficiency induced by somatostatin analogs and can be treated with pancreatic enzymes from both of those drugs.
Perfect, that's the next question on here, that in compare it to the suppression of pancreatic enzymes, they're the same, suppression of growth hormone, they're the same. The trouble is that to compare these, you have to compare apples to apples and oranges to oranges. If you take 10 milligrams of LAR and compare it to 120 of Somatuline Depot twice a month, you know who's going to be the winner or the loser, as the case may be. And the only way you're going to be able to compare these things is by knowing how much you need in the blood to saturate receptors, et cetera, and then controlling it, because we know that heavy people like me, if you give me the dose of octreotide or Somatuline Depot, and you give Dr. Wallen, this little skinny rat over here, who runs a marathon, the same dose, he's going to have way higher blood levels than the big fat guy. Okay, it's just the way it is. What level of calcitonin is considered diagnostic of a medullary carcinoma? Is biopsy necessary to confirm MTC, i.e., I got a calcitonin and a positive pentagastrin stem, do I need a biopsy?
And you're a member of an MEN2 family, presumably?
I don't know, they didn't say that.
Okay. So in our particular lab, the cutoff for normal is 5 picograms per mil, I believe. And if you're, in a recent series that we looked at, if you're over that at all and you have this family history, then we would offer prophylactic thyroidectomy for those people.
Okay. Danny, you talked about diagnosis and treatment of diarrhea. How does having a lot of lower GI gas affect the treatment?
A lot of lower GI gas commonly is related to malabsorption of food, so a lot of calories are delivered to the colon, bacteria kind of chew up those calories. So as far as management, kind of a low carbohydrate diet and treatment of fat malabsorption are primary. And then for some patients, they feel bloated, especially with a lot of fiber. So that would be one mechanism to treat those patients with that symptom. A lot of gas and bloating. Another way would be to treat to decrease the fiber in their diet.
Okay? Leanne, foods that will increase serotonin. Your favorite question.
Foods that are preceptors of serotonin are tyramine and tryptophan, basically.
Okay, what kind of food has tyramine in it? What kind of food has
Most of these
tryptophan
are
in it?
protein sources, animal proteins in particular.
What about blue
and
cheese?
Cheese.
Ah, blue cheese. So cheese, what about red wine?
Red wine.
Has
also
tyramine in it. Okay, so lots of food. We usually tell people that if it's fermented, it probably has a boatload of tyramine in it. Okay, Dr. Wolin and Dr. Howe. Will slides of your presentation be available online? The video that's happening will be online, but I don't think slides will be. Lanreotide trough levels, 7,400 and 5,000. How should I think about this? You're in the saturated range. What causes trough fluctuations? Was it drawn exactly the same number of hours and days after the injection? Did you have a bad injection? Was one deeper than the other? Was it bad phase of the moon? I don't know. Why this stuff happens in the body, trust me, after doing this for 30 years, I don't understand the body any better than I did when I started. Dr. Howe, are all thyroid cancers neuroendocrine based? Ooh, that's a good one.
No, just the medullary ones.
Okay. Dr. Rain, should sugar malabsorption more specifically be called fructose malabsorption?
No, because there's a lot of other sugars besides fructose.
Okay. Hold on, I gotta reload here.
So sugar is
Okay, here we go. Can taking Creon cause diarrhea?
Can taking Creon, I've never heard of that, no.
Okay. My primary oncologist did not prescribe the Creon, but a second opinion oncologist prescribed it to me. Now I have diarrhea, should I stop taking the Creon? Are you taking Sandostatin LAR all of a sudden? Did you increase the dose? I mean, there are 1,000 things. I think that was Danny's point. There are 1,000 things that cause diarrhea. You know, the way I tell people myself is stop it for 2 weeks. The diarrhea goes away, start it up. See if it comes back, then you got your answer. Does juicing cause diarrhea?
If it has a high concentrated sweets, it can, especially if you've had short bowel.
Okay, what about probiotics? You like them?
I like probiotics.
Okay, good. Go out and buy Leanne's probiotics. Dr. Raines, sugarless gum make me have diarrhea.
Absolutely.
Absolutely. Dr. Wolin, is everolimus and octreotide a better combination to shrink peanuts than Xeloda and Timidar? How hot, this is one of those how hot's hot questions. Well, it's true, but it depends for every person is different. What do you think, Ed?
I think that's true. If somebody's never been treated with any type of chemotherapy and they get Temidor and Xeloda, the chances of having a major shrinkage of a pancreatic neuroendocrine tumor is greater than the chances of having a major shrink with everolimus. And
I think that's true. And I think it's no more toxic. I mean, I'm amazed how well Xeloda.
One thing we have to be careful though when we say these things is that there's never been a trial of everolimus plus Sandostatin.
We're guessing.
And there's only been one trial of CAP-10, and it's that order, CAP-10 for neuroendocrine tumors, and that's Rob Fine's trial, which he hasn't published yet. It's submitted for publication, but I agree with that a CAP-10, and it's important that it's sequenced that way, that you get the capecitabine first and the capecitabine first and the temozolomide after, showed some very impressive responses in fairly bulky disease. But the important thing at this stage is that there's never been a comparison. They've never been studied head-to-head. And there's never been a trial that I'm aware of EV plus sandostatin. There's currently a randomized trial of everolimus and pasireotide, which is another analog, a somatostatin receptor blocking analog, compared to everolimus alone. And that trial will finish accrual in December, and hopefully there'll be results of that study in a year or so. And that'll be the first trial where everolimus is combined with a somatostatin receptor inhibitor, and hopefully that'll shed some light.
There actually are some other trials as well. James Yao and MD Anderson has compared everolimus alone versus everolimus plus octreotide, and there seemed to be a benefit with the combination. There are at least 3 published trials so far of capecitabine, which is Xeloda in combination with temozolomide. They all look like they have response rates higher than the response rates that have been reported for everolimus. However, as was pointed out, they haven't been compared head-to-head in a prospective randomized way.
And they never probably will be. I mean, that's the bottom line is it's hard to do these trials, and there has to be an economic reason. And if you have 2 opposing drug companies doing something, everolimus and octreotide both belong to Novartis. They're happy to study that. Ask them to take their drug and put it up against their competitor's drug. They'll tell you to go eat. When would you use angiography on a distal pancreatic lesion that's highly vascular? Would you routinely angiogram that person?
No.
Okay, Dr. Howe, should you check children for hereditary markers if you have PNAS? Nothing else, just the pancreatic neuron.
If the parent has a PNET or if the child has a PNET?
The parent has a PNAS.
Well, so you're talking about checking for either VHL or MEN1, and you'd probably want to have at least more than one component of those diseases. So if you just have one
Totally
component.
agree. I don't genetically screen my PNAS patients. If they had parathyroid disease, yes. If there was somebody else in the family, like the brother had a PNAT, then I probably would. Something would have to make me more suspicious than the routine brown bear walking through the backyard. Should all carcinoid syndrome patients have rescue shots? I think the answer is yes. Ed?
Yes.
Steve? James? Sure. Yeah, there you go. Is there a nutritional net health value of bananas?
Yes, bananas are soluble fibers and they can help decrease diarrhea, and they're also very high in potassium.
And they're high in serotonin,
If
guys.
they don't cause you to flush. Now, if it's an old banana or been very ripe, it may cause you to flush.
My mother ate 2 bananas every day of her life. I said, Mom, they contain a lot of serotonin. She said, be quiet.
Who's over the age of 40? If you're over the age of 40, you remember when kaopectate wasn't just Pepto-Bismol packaged as kaopectate, right? You remember when kaopectate was actually that pasty white stuff that actually worked really well to stop diarrhea? Pectin is in kaopectate, and pectin is in bananas.
And in apples and all kinds of stuff. And in, when you make jelly, Dr. Raines, are cheeses included in the milk category making your diarrhea worse? I.e., if you have lactose intolerance, is cheese just as bad as ice cream?
Not just as bad, but yes, it's included.
Yogurt, what about yogurt?
No.
No, yogurt's not going to give you lactose intolerance. There's your answer. Dr. Howe, diagnosis of islet cell PNET based on the exam of a small needle biopsy from the liver met. Does it make sense that you get a larger chunk taken from the primary and the pancreas for analysis to better understand the disease? They already got a diagnosis based on a liver biopsy.
Well, and I assume that on CT scan there's pancreatic mass, but the liver biopsy isn't going to sort out, as Dr. Michael showed, they all look the same, so it's not going to sort out whether that's from the small bowel or the pancreas. So, but let's say you have a CT mass and you presume it's from the pancreas, I don't think it's going to help you change your management based upon histology or staining.
Okay, I'm going to take this one. Will upping your LAR dose from 20 to 30 help reduce flushing? I guess the answer is it's intuitively obvious that going from 20 to 30, it sounds like that's a great idea. If you look at the original registration trial of LAR published by Novartis, that compared sub-Q to 10 milligrams, 20 milligrams, and 30 milligrams, the incidence of flushing, the incidence of diarrhea was essentially the same between 100 3 times a day of sub-Q, 10 milligrams, 20 milligrams, and 30 milligrams a month. And it's not quite known why that is. What about LX1606 oral medicine, something to help control the release of serotonin? As you can go out and see the nice people out there, that trial is really getting ready to rock and roll. Preliminary data looks promising. Stay tuned for the real thing. Dr. Mullen, does it increase progression-free survival always predict improved overall survival? Good question.
Is there someone from the FDA out there?
Yeah, I like that. Yeah, go. You in. You the man.
In the case of slow-growing tumors, like neuroendocrine tumors that are well-differentiated, which is what we've been spending this meeting talking about, it appears to be related to survival, but it hasn't been rigorously proven with randomized trials, probably never will be, because people are living so long and doing so well, but all of those people that are long-term survivors with the disease have long progression-free survival with no evidence of cancer growing. So I think the answer is going to be yes, but data that is actually hard to find in clinical trials.
Here's another reason why it'll never be, it's like a question that'll never really have an answer, and Dr. Mullen's absolutely right. If you're on a trial that's trying to ask that question, overall survival trial, and you progress, odds are you're going to go and take something else. You're not going to just accept the fact that you progressed on the trial and you're going to say, okay, I progressed and here I go, I'm just going to wait until I actually die of the disease. And because you go and take something else means that overall survival is a very difficult endpoint to get your arms around in a clinical trial. And Dr. Mullen's absolutely right. In slow-growing tumors, it appears that progression-free and overall may be synonymous. But in other tumor types like breast cancer, for example, it's been shown that progression-free survival does not translate necessarily to an overall survival benefit.
And I think, listen very carefully to what Steve's saying, is that as we get better and better and better and better and better at treating things, as more things come on the market, PRRT buys you 3 years, everolimus buys you 9 months, octreotide buys you X, Y, or Z time. It's sort of like playing in a poker tournament. Every time you did something, you get more chips. As long as you have one chip, you're still in the game. So, the thing is that, like Steve said, nobody does one thing. What was it? You can't eat one potato chip, something like that? Yeah. It's the same kind of thing. Nobody gets one therapy. So you fail this thing, you go on the next thing. You fail that thing, you go on the next thing. Everything buys you a little bit. Hopefully. That's the hope. Okay. Let's see. Comment on black raspberry extract. For me, black raspberry extract, I recommend to people who we've tested their tumor and people who have diarrhea. It seems to work really, really well for diarrhea. It has a lot of pectin in it. It has a lot of soluble fiber. It works pretty well for diarrhea. Tumor control it's very effective in our in vitro assay. Steve Dunn from Berry Health, I think, is working on a trial with the help of the folks from the University of Wisconsin, where we're going to actually look at randomizing some people based on tissue testing, yes or no, black raspberry. How does one manage mood swings and insomnia with carcinoids? Just like in normal people. I don't think do you restrict the use of SSRIs or anything else in your patients?
No, for reasons you've discussed previously.
Steve? No? James? No. Me either. Okay, once the primary is completely resected, do new metastases continue to appear? Of course. Otherwise, we cure everybody. Next. Dr. Williams, how is bacterial overgrowth treated? I know you answered it, but how long do I need to stay on a low carbohydrate diet?
Low carbohydrate diet, kind of indefinitely, but generally we give people courses of antibiotic therapy, hopefully 2 weeks at a time, 2 weeks, and maybe that'll last 3 months, and then maybe another 2 weeks. And you do that serial antibiotic therapy a couple times a year, or hopefully, just a few times a year, and 2-week courses.
We're running out of time, guys. If you guys want to stay for an extra 15 minutes, add 15 minutes to the time. That's okay by me. Yes, okay. Add 15 minutes more. That's all I can take. Dr. Wallen, when would you recommend using lanreotide or pasreotide? What markers do you recommend to be used with these?
Neither one of those drugs has yet been approved for neuroendocrine tumors, and lanreotide is on the market for certain indications of pituitary tumors, so that sometimes it can be used off-label. Lanreotide is particularly useful if patients either can pay for it or they can get payment through their insurance, particularly for people that are obese and it's difficult to get a proper intramuscular injection of octreotide. It's good for people that are very thin and they don't really have enough muscle mass for deep intramuscular injections. It's also convenient if people are doing a lot of traveling and need a subcutaneous injection that doesn't necessarily have to be given in a physician's office. So there's several potential advantages, but again, it's not as available as we like it to be. Pasreotide is not approved in the United States for any...
Not available.
It's not available.
You can't even get it if you want.
Except on clinical trials.
Yeah, except on clinical.
And there are multiple clinical trials, so anybody who is potentially interested in pasreotide should, consult a center that has access to it.
Yeah. Do nuts cause kidney stones? One little quick comment. Remember that people who have had ileal resections have high incidence of kidney stones, like people with Crohn's disease. Do nuts cause kidney stones? I'm nuts. Do I cause kidney stones? Yes, so there you go.
I think that's
Thank you very much for the peanut
very
gallery.
good. I don't know that there's enough research to say it, Danny. Do you see any?
No, okay. Dr. Raines, is there any downside for taking pancreatic enzymes long-term other than depleting your pocketbook?
No.
No. Dr. Labuti, can chemotherapy perfusion liver be effective in the face of mets to other areas such as lymph, spleen, bone? That's a great question.
Very good question.
It's a very good question, very thoughtful. Whoever wrote that, you get an A for that.
So lymph nodes, not so much of a concern either for the operative approach or the percutaneous approach, but if there is significant disease outside of the liver, we tend not to do the operative approach. Again, that analogy of the scale, weighing risk-benefit, to go through a major operative procedure, you want to get as much benefit as possible.
Mouse.
Yeah, elephant mouse. But for the percutaneous approach, once that's online, I think that will be available for managing the most immediate life-threatening site, which is often the liver, or for symptoms. And so that I think we would do, and then combine with other strategies to treat the disease in the other locations.
If anybody in here was fortunate or unfortunate enough to have to go through organic chemistry, they used to talk about the rate-limiting step in making a drug or doing a reaction. And many times, the liver is the rate-limiting step. It's the thing that's going to either kill you or keep you alive. If Steve can decrease the tumor burden in your liver, if we can do it surgically, if you can do it with a liver transplant or a multivisceral organ transplant, however you can do it, you can beat it, you can fry it, you can cook it, you can nano-knife it. If you can decrease it, you can keep people alive longer. This is another A for the day question, going to Dr. Howe. I get asked this 100 times a week. Does carcinoid tumor relate to MEN1 and MEN2? If so, which carcinoid tumor?
Okay, so in MEN1, there's like I showed in that slide, there's a 17% incidence of carcinoid tumors, mostly the bronchus, and then they can get gastric ones, especially if they're making too much gastrin, because that'll cause gastric carcinoid formation. MEN2, not so aware of that.
Thymic carcinoid's a little gland that you have when you're a kid and it goes away when you're an adult, associated with MEN1. Bronchial carcinoids, gastrics, not so much ileals, not so much rectals. So again, PNETs, yes, clearly, absolutely. Given a Afinitor for 2 months, the Sutent for 6 months, how do you determine whether the tumor shrinkage is the result of Sutent or a delayed response to Afinitor? And how do you figure out where the roots of a tree are and the leaves? The latter is my own comment.
Normally, when chemotherapy programs or systemic treatment programs are changed, it's because the first one is either not working or it's intolerable. If something is working, you normally don't change. So if something was changed after 2 months, the question is why. If somebody is having side effects, sometimes the dose can be reduced and side effects controlled. Before making a change in treatment, I think it's important to have new imaging, whether it's a CT or an MRI, some means of assessing the cancer, and you know if it's working by getting another scan a few months later, and you see it's either better, worse, or the same, and you know what you're doing. But otherwise, if you didn't do any imaging and you had nothing to follow, you would not know the answer to that question.
Okay, Leanne, oh, this is loaded, I'm gonna love this one. Is green coffee extract good to take? Remember, the more you roast a coffee bean, the less caffeine it has in it. The highest caffeine level is in green coffee beans. So if you want to blow your earlobes off, you remember caffeine is part of the ene family. Epinephrine, norepinephrine, caffeine, theobromine, theophylline, all the enes. What about green coffee?
I would not.
Use it for an enema. Dr. Wayne, cholesterol interfere with the absorption of nutrients from food or medication?
Yes.
Yes. Okay, which
But-
one?
Especially, I think cholesterol interferes with absorption of a lot of different medications, and generally they recommend you take it separately from medications, say, an hour before, or take them in between meals and take your medicines with meals, because there's kind of a long list of interactions with cholesterol absorption, medication absorption with cholesterol.
Let me just tell you, living proof in black and white why multidisciplinary stuff and the approach to a multidisciplinary approach to this is really critical. You know, these are kinds of questions that I don't know the answer to, but he does. And that's what makes multidisciplinary approaches so much stronger. Dr. Wallen, is the topside carboplatinum the standard agent given to a high-grade tumor with a Ki-67 greater than 80%?
If anything is standard, it would be using a platinum drug, either cisplatinum or carboplatinum, in combination with etoposide. And those are the most active programs that are widely used in America. Combinations with platinum and irinotecan are also used in some parts of the world and probably are close in efficacy.
Okay, apparently I'm getting chastised. I didn't answer the question. Lab tests for use with lanreotide. There is a radioimmunoassay for octreotide. There's a radioimmunoassay for lanreotide. You gotta order the right one. If you're on somatulene, you order a lanreotide value. If you're on LAR or the pump, you order an octreotide. You don't measure octreotide levels if you're on the sub-Q injections like 3 or 4 times a day, because it goes up and down like a roller coaster. Leanne had a small bowel obstruction or an ileus recently, told to stay on a low fiber, low residue diet, already needing to gain weight, but dairy products are poorly tolerated. Most drink weight supplements are dairy-based. Any suggestions?
The first part were the low residue, when I was talking about fibers, the insoluble fibers, so whole grains with the exception of oatmeal. Those are the type of fibers or the residue that we're working with. There is a little residue in milk, you're not drinking it anyway, but we don't worry about that quite as much anymore. So it's really the roughage that you're going to get in the raw vegetables and the peels of your fruits. And not the insides necessarily.
Another A for the day question. This is for everybody. Steve, Jim, Ed, me, if you had a poorly differentiated peanut, and you had bone, liver, a lung, mets, what about resecting a primary in high-grade disease rather than low-grade disease?
In terms of influence of outcome?
Yeah,
So I think with a high-grade pancreatic neuroendocrine tumor with liver, lung, and bone metastases and a primary in place, resecting the primary is like polishing the banister in your house while the house is on fire.
Right.
So I wouldn't focus on it at
it's
all.
meddlesome. Now, change
Now,
that.
the only exception to that is, you know,
If
if
it's a symptom or.
yeah, if
or
the
you're-
volume of disease in the metastatic sites is very small and there's a bulky but resectable lesion
Yeah.
until the
But
pancreas.
then
it's a
there you're
functional
resecting
tumor.
for symptoms
Yeah.
or complications, not for its effect on overall survival. Do you agree?
For high grade, maybe, low grade,
No, low grade, we all agree on. What about high grade? KI 67, 90%, mets everywhere, 142 bone mets.
If the disease systemically wasn't that huge, and we could do a PRRT,
Okay.
if the tumor burden wasn't massive, then you could consider resecting the primary and then treating with PRRT. I mean, you could.
Okay, so the answer,
Probably do it.
the other way, yeah. I mean, I don't know, again, the concept is PRRT works with better with lower volume disease. Not proven yet, but certainly I think everybody who does it sort of suspects that. You agree, Ed?
That's true, and also I just wanted to point out that PRRT is not, a standard, let's say, for high-grade tumors like this. I would certainly start right off the bat with chemotherapy. I wouldn't do any type of surgery unless it were for some really major symptoms that had to be palliated. And if there's any consideration about surgery, even for bulk tumor, I would think about doing it as salvage surgery to mop up after the best possible response to chemotherapy.
3 minutes. Okay, Danny, any danger in increasing the intake of pancrease to help control the malabsorption? Can you take too much of the dang on stuff, other than going broke?
Oh, no. There is an associated with microscopic colitis, I guess, but I don't know.
So we have another.
But I would stick to the 30,000 units of lipase per meal, and if you take more, if you're taking 30,000 international units of lipase per meal, taking more is probably not making a difference. So
Okay, Leanne,
I wouldn't take
Danny, we're down to 2 minutes and 50 seconds. How do you avoid dehydration with malabsorption and diarrhea?
Leanne?
If you, we can use isotonic solutions. There's a couple on the market. I'm glad to give some of those to you that will not increase your diarrhea quite so much. And then small, frequent amounts, not a concentrated sweet like like your energy drinks anymore. But or dilute. If you ever drink a concentrated sweet enzyme, replacement, mix it 3 to 1. 3 parts of water to 1 part of the solution that you're drinking.
Okay, we're down to 2 minutes. Dr. Raines and Leanne, boy, you're getting hit. What causes the gas that comes with carcinoid foods? Where does the gas come from? You swallow air, air gets absorbed, leaving methane gas. Okay, that's true, but bacteria produce methane gas.
Soluble fibers will produce gas.
Yeah. Yes.
That's how your feces will float.
That's why. Floating feces. Okay. How does everolimus work beyond its effect on mTOR and tumor? For example, in what ways does it affect the immune system just through white blood cells or by other routes? Yeah.
mTOR inhibitors, all of them, including everolimus, weaken the immune system by its effect on lymphocyte blood cells. It's used in immunosuppression after people have organ transplants. However, amount of immunosuppression when it's used for treating neuroendocrine tumors is minimal, and the severe immune suppression happens when people take steroid medicines like prednisone at the same time. So as long as you're not taking steroid medicines and everolimus at the same time, it's usually mild immunosuppression.
Last question of the day. Leanne, take it away. Are sugar substitutes okay to use?
I think at the discretion of your physician. There are some
That's what it
sweeteners. There are some sweeteners.
Waffling.
There's a new sweetener on the market that is plant-based from the stevia plant. I think it has been researched by the FDA and has been approved. I have a son that's a diabetic, and I'm not afraid of him using sweeteners if that, in a personal note. So I don't see a lot of side effects. There are a few, if you're in doubt, just, small amounts infrequently.
Okay, Leanne, Alice or speakers, okay, another message? 2 a.m. tonight for the expo. The expo tonight. So if you're going to the expo tonight, at 2 a.m., you're on 2 now. 2 a.m. is one half a floor up. So, all right, remember guys, sorry, I still got, a huge number of questions. I'll try to keep these and move along next.